Hi, this is Unlimited Access. My name is Levi.
Hi, I'm Shannon Ellsworth.
Hi, and I'm Ulrike Berzau.
Great. And so, as you've seen, we've been transitioning the show from conversations between Shannon and me. And again, I'm just a content creator and a show host and somebody trying to keep the conversation going. Shannon, you are an expert in the industry, whether you want to own it or not. You're really smart and savvy to it. But what we've been trying to do is bring other experts in to help us really have a deeper, more meaningful conversation. I think, Shannon, one of the things that you've been trying to do is not only talk from your level of expertise, but bring in somebody else that has maybe more expertise than you in certain subjects. And we're going to do that with Ulrike today, right, Shannon?
Yeah. So I think to say I'm an expert in the industry is really like what I've learned is healthcare is a broad industry. You're not an expert in everything. You're not going to be. It's how you bring the pieces together. I am a technologist, a caregiver, a patient, and a lover of solving problems, and also have healthcare in my family. So there are areas where I'm just not sophisticated enough and I learn from, and I think we said this for the last one, is it's time for other people to hear and see who I learn from. I actually got asked on the podcast last week from this guy. He said, how have you, a non-traditional healthcare person, come into the industry and learned as much as you did? And I said, a lot of great mentors who, and Ulrike is a great example of one who I never expected to be a mentor in this. We met from horses. You guys have seen my horse video, and back pain, and ended up in this crazy world called records and polychronic conditions. And so that's the goal, is to really extend what I've learned over the last 2 years and why I have my thoughts. And then there's patience. Listen, you can't be an expert at anything. So really listening to those stories, letting people hear what I've heard, and our mission to help get better care.
Let's go ahead and introduce our guest today. Ulrike, can you just kick things off? Let us know a little bit about your journey and your experience in the healthcare world as an executive and a consultant.
So for most of my career, I've been leading rehabilitation services, rehabilitation hospitals. And in Boston, I worked together with the Harvard physicians. Also during my career, I've been working together with different health science programs and done a lot of international consulting in the Middle East, in Canada, and of course in the U.S. in the areas of rehab and post-acute services. And you did notice I have a German accent. So I grew up in Germany, which means I am very familiar with the German healthcare system as well.
In addition to like your executive world and public health, how does your real world experience, especially being so international, enrich both, but the things that you're doing as a teaching and in academia? Are you able to bridge all these worlds together?
Yes, and it's very exciting because I do believe to teach something, you have to have the actual experience, or at least being involved in it to make it more relevant. So I do teach in the public health program at the Freddie Dickinson University, public health and public administration. And it's very exciting to see what the students, typically healthcare students, are dealing with, and how I can help them to learn more and also think about innovation, think about future opportunities, think about how we could change healthcare to the better.
I think that's a fascinating segue, because I think, we look at your experience. You and I have talked about your experience in the rehab hospitals and just how do you navigate all the different things that you have to meaningful use, and how do we fit in, and how do we make sure that what we're trying to do also includes patient safety concerns. And what I found fascinating is you're like, let me see if I can get a student to write a paper, or if we think about what's really happened in healthcare is all around technology, and every generation of doctors, physicians have a different level of technology. Well, some of the younger kids, I mean, they were born with phones in their hand. So their ability to think really big, and that's what's putting so much pressure on the industry, is these guys are like, they're demanding it, where the rest of us are like, yeah, I like it. I don't, I want it for the sake of being more productive, but it's not a demand from us. So I think that was a really interesting thing that you kind of taught me. You're like, look, you can get these partnerships with universities who are really looking at thinking bigger, bigger, maybe better, maybe not, just unique ways of coming in from an innovation perspective that's really taught me and the team to look at who could we partner with to kind of take our vision and amplify it 10 years out.
Definitely. It's very exciting to teach because there's so much we can learn from the students, and it's almost you're planting a seed and they can take it to the next level with the research and their own little bit of experience and adding my experience. So it's really exciting.
I think the last one was on the EMRs when you had the students writing like papers on globally what was going on with the EHRs, EMR systems, and which ones had it and how France had a whole, let's see if we can separate it. That was the first, I think, insight I saw to a global need. We never really thought about it that well. We did think about it, but it got kind of overwhelming when you think globally. How do you do it? But it truly is a worldwide problem. So that's really
Definitely. It's a worldwide problem, but also there are many, many things we can learn from other countries. Like Israel and Denmark are leading. And I know when I grew up in Germany, we had already some system is more centralized, but it's not yet there where we want it to be. So we can learn from other countries. It's very inspiring to learn from.
Yeah. So Denmark and what was the other one?
Israel. That's my recent research showed that Israel and Denmark are actually leading in finding a more consistent approach to seamless, data sharing and to a centralized portal for having all the health records there.
I'm writing that down now.
Do you feel there's like some sort of like, well, we also know there's a benefit. Is it really the redundancy of the information if we have to go through multiple platforms? What are the real benefits and challenges for the patient and or the hospital system?
Definitely, it's a huge administrative burden. And, healthcare is very expensive because of the administrative costs. And one of the administrative burden is the redundancy of adding all the same information everywhere. You go to your primary care, you go to the hospital, you go to diagnostic imaging, wherever the patient is going, and you have to complete the same information over and over again. And then in patients, what I hear from patients when they have the different portals, different EHRs have the different patient portals, but they don't remember which portal was where, which password, and how to access the information. When you have so many different portals that are actually siloed because you only have a certain information in that, let's say from your primary care, but then maybe the patient needed a specialist or the patient had an urgent care visit, and it's all siloed and not streamlined and not accessible. So the patient cannot be part of the care and their providers don't know what happened to the patient because the patient went somewhere else, and then it's just very siloed, very disjointed, and takes a lot of time to read through that.
How significant do you think that this is going to be then so we see other countries that we were talking about, Ulrike, really making these really great gains, right? So if Israel and Denmark are, let's say they're the pinnacle of what we want to try to get to, and Germany's on their way. Let me ask you this. How far behind do you think the U.S. is? Like, if let's go on a scale of 1 to 10, Israel 10, Germany maybe an 8, where do you see the U.S. in this?
I would say that the U.S. has a lot of opportunities for improvement. And it's because the U.S. has so many different, first the states and then the different hospitals, the health system. And it's in a way a little bit a competitive environment. And amazing EHRs have been developed, but they don't talk to each other. And in my career, I've been through 4 mergers and acquisitions. And it was every time a significant challenge to understand, to connect the different providers together in the hospitals. So the US has a lot of opportunity to improve, and I don't want to grade it on any kind of.
Love it. I can hear you reframing, Ulrike. That's a very great way to say we suck. No, you didn't say that, but it's a really great way to say, listen, compared to others, we're pretty far down, which I think it's known, right? We have the worst outcomes, the highest costs, and I think it would be interesting, and maybe this is something we do, is we look across the different countries that you say are more advanced, and we go, what are they doing? And can we do this? One of the things I learned from handling Europe and South America is the countries function as a state. But what they don't have is this federal governing body. They have, the euro, the Brexit, what's the governing body for Europe that tries to work? The EU,
yeah.
right? The EU tries to set rules, but it's not like the federal government where it's owned. So what happens is, as it gets implemented, it breaks apart. So if you were to judge fairly the EU versus the US, that to me is an apples to apples comparison. If you say, and this is one of the things I learned is, I think you even said from New Jersey to Denver, there was a difference because once they implement in the state rule, and the reason they do that is you're trying to follow the disease process. So there are indications that happen with chronic illnesses. Listen, people in Florida are probably going to have higher stats of melanoma. People in Syracuse, actually, in upstate New York tend to be weight-related issues because we have a lot of snow, not a lot of movement. So heavier people. And so diabetes, things like that tend to be more prevalent. And so what happens is they put the decision-making in the hands of the states. And so each state is different. So I think that's where I really struggle with how do you rank them without saying, okay, let's do apples to apples. Because and that's what I learned. Like in Europe, I was like, listen, you can go to England and they're like, listen, we've got a single payer system. We hate it. You can buy up in care. It's what is it? It's like Obamacare for them, whatever you call what's the term? Not a single payer, but national country health insurance.
Yeah.
But so they're like, listen, it's not great. Your wait times are forever. You can't get in for 9 months, but you can buy up like concierge care. If you have money, you can buy up, but at least everybody gets covered. So there is some level of implementation that's consistent where we don't really, nor will we have a consistency unless we start to put some standards. And that's what the ONC and those guys try to do. But it kind of gets diluted as it moves down into the states. So it's a really hard, to your credit, Ulrike, I think that's a really tough question to answer because it's not apples to apples.
Yeah, and global health issues are far beyond, today's conversation, but it's very interesting to learn from other countries. And you have to look back at the history of the German healthcare system. It was developed by Bismarck maybe almost 150 years ago. Something grew gradually, and it's a smaller country. It was developed and managed and streamlined. So I think it's, there's a lot we could discuss, but I think it's beyond most probably in today's conversation.
It's a good, I don't know if it's beyond it. It's just, I think it goes back to Levi's question, which is how are we doing? How do we rate it? And then where do we start and not get, I had this great term. I have a mentor, there's so many great mentors. And she said, do not get sucked into comparisonitis. Never heard that word. I think she made it up, but comparisonitis, like comparing yourself, it's a benchmark, but it really has to be relative to what we're living with and what we're dealing with. And, even generational differences with the internet have made such a big difference.
Well, I think it's a fascinating conversation just because we've never discussed anything international in the last year.
Right?
And, we didn't even consider that as we were planning this particular recording. We did talk about the international perspective that you have. So let's make a transition. Let's go to something different. There's a new term that I'm not familiar with that I saw in our preparation, in our notes, that you have a role. It's CARF, or is it CARF? Is that how you say it?
Yes, CARF.
Let our listeners know, what is that and what is your role in that?
CARF is the Commission on Accreditation of Rehabilitation Facilities. And I have been a CARF surveyor since 2006. And I've surveyed at least 60 organizations in the U.S. and many internationally, including the Middle East. So CARF has standards and for accreditation for rehab. And my role was in the physical rehab. There is also behavioral and other sections or other departments in CARF. Now, what's very interesting is that CARF actually implemented in 2010 a standard that is ask organizations to help the patients to have a portable profile. So the patient has something in their hand or online where they have their own personal health records. And this is for patients in the CARF standards, of course, as patients with or people with different disabilities. And imagine like a brain injury patient who the caregiver needs to know about all the different care needs, the physician, the medical equipment, the adaptive equipment, the appointments and everything. So CARF implemented that standard to ask the organization, the rehab facilities, to really help the patients to create those kind of portable profiles. So then when the patients get discharged, they have something in their hand or online. Now, while the standard has had a great intention and it's now a bit more refined, there were different processes implemented. Some organizations created something online to meet the standard. Some created actually physical medical passport. And, when you create something in writing, like handwritten, there's a lot of error, of course, because when, today's medication or today's adaptive equipment might not be tomorrow anymore the right thing for that patient. So that standard has been developed. It's still in the CARF accreditation manual, and still organizations are asked to help the patient to have a process. And I can see Ursamin would be an amazing process to really help people with disabilities and the caregivers to have a centralized record where they not only have all the medical needs, but especially their equipment. And, we have medical equipment and we have adaptive equipment, and the adaptive equipment helps them to be more independent and, including AI and all of those fancy things. So I can see Ursamin has a huge role in that and would be so helpful for those with disabilities.
That's really interesting. I think you and I had talked about that before. The question I had at the time, and I think I still have it, which is how do we measure that success? That's what I always hear is like, how do we show that we can, like, because the accreditation, do we help you get like just a portable health record? Everybody knows quote unquote the value of that. But then they're like, okay, how do you prove that? And I'm like, I feel like a little redundant. And like, I think we've all agreed that this is necessary. And so then how do you prove? And I don't know if that goes back to like, who uses those ratings? And then how do you approve that you can get those ratings? Because you and I talked about that. I was like, that's fantastic. Like, that's like the number one thing. We can help doctors do that. But who looks at those? Do patients look at them? Does Medicare look at them? Is it just the doctors who are judging each other? What is it that the end user who is watching those numbers?
Yeah. So CARF accreditation is a gold seal for rehabilitation facilities, and they have to be reaccredited regularly. Like other hospitals, it's voluntary, but hospitals in general are accredited by Joint Commission, and that is again a gold seal of approval. And rehab facilities use CARF. Sometimes they use CARF and Joint Commission, both or either one. So when patients and providers are looking for rehabilitation facilities, they look at the outcomes, they look at the available data online, and also they look at accreditation or awards. And accreditation is meeting like a university is accredited for certain programs. So rehab facilities are accredited. And in order for the organization to meet that CARF standard, they needed to find different ways how to create that portable health profile. There were then some companies came up with something online, and then some with paper, and we mentioned that earlier. So it is really, if Ursamin is implemented everywhere, it would be just supporting the organization to meet the standard. For example, the veteran hospital or system, they have a system, it's called My Health EVET. And the My Health EVET actually meets part of the CARF standards. And I have surveyed different veteran facilities, and I've looked at the My Health eBed records, and it is pretty much like a portable profile. It doesn't meet all the standards because CARF has then A, B, C, D, E, whatever has to be in that. But it met, I think, everything but 4 little points. So that supports the veteran system to meet the CARF accreditation. Just this one specific standard. There are many, many more standards. I mean, this is just one standards out of, I don't know, hundreds and thousands they have to meet.
Do you feel it's like, so there's so many standards that are out there. Do you feel the patient is aware that this is even going on behind the scenes?
I think patients, when they're in the rehab facility, they are aware what would help them, and they're really are looking for something that can help them to manage the incredible information overload. And let's say caregiver, as patient is like, let's say a family member has a brain injury, and the caregiver says, "Oh, I don't even know where to start. I don't know all the physician, the medication. I don't know all the equipment. When once they're discharged, when I need to reorder something, where do I go? How do I find it?" It's very, very overwhelming. And of course, there's a process from each rehab facility to follow up and support them as much as possible. But again, Ursamin would be an amazing opportunity to help the patients or the caregiver to feel at ease and say, okay, I know here is everything I need. It's one portal, one access, and one password. And it's where I can find what I need, and which is dynamic. It can be improved. It can be added to it. It's not static. It's not when I get discharged, that's what it is. No, it's continuously updated. And also, I know you have education in Ursamin, and you have other, let's say, supportive information or websites and access to, let's say, brain injury association and whatever needed for that specific patient.
Well, that's I didn't even know that existed. So as like I say, as a patient on the patient side of things, it just seems to me like there's a lot of people like yourself, Shannon, in the industry that are really trying to do a lot of really good things, right? I don't think anybody's really trying to, screw the patient over, right? Everybody's trying to do something new, but it seems to me like they're just all going off in all these different directions. And standards, like the one that you're talking about with CARF, is one of those things that's going to help the patient really just not only get treated better, but it seems to me like it's going to make it a lot more simple.
Yes.
Well, let's transition to kind of one final thing here. And, I like, because you have a lot of experience in this industry, and I think Shannon and you can have a great conversation about this. But it's like, with your vast level of experience, what are some of the improvements that you would like to see? Like, let's get rid of all the nation states or any other things that are preventing us from doing perfect healthcare. What does it look like from your perspective? What's perfect healthcare? What are some of the improvements you'd like to see in the industry?
So I would take this question from the rehab perspective, because really my main experience is in rehab and the continuum of care. The continuum of care has so many different levels, and it can all work together seamlessly, or it can all be disjointed. And if I see one key improvement is having, again, all the health information of the patient in one place. So one portal, one platform. When patients get discharged from acute care to, let's say, the next level of the continuum, there are so many different levels. And the different rehab facilities, skilled facilities, they have to find out if the patient is appropriate for their level of care and if the insurance would also support that. So they have to access the records, and there's so much time spent in finding the records and in finding, accessing them. Let's say if it's part of the same system, it's easier. But if it's a hospital somewhere in the nowhere, a critical access hospital, and the patient needs rehab and the rehab facility is somewhere else, until the intake coordinators get the information, it takes a long, long time. And the old times they were even faxed. So today with Ursamin, you could just look at the record and you would have everything together. You would have the EHR connecting to Ursamin. You would have the patient portal and all of that. So you can easily, with access to record, with again reduce your administrative time and actually be much more appropriate and much more like appropriate in the way you achieve better patient outcomes if you get the patient to the right setting. If a patient needs rehab, skilled home care, long-term acute care, outpatient. So in order to determine what's the most appropriate setting is, you do need to have access to the records. And it's again, one platform, one place where everything is. That would be my number one thing to improve. And number one and number two, number three, it's all the same. One place to access the records, and also for all stakeholders and all appropriate stakeholders. Remember, I know Ursamin is encrypted. It is highly secure. It's HIPAA compliant and all of that, which is important because you want to have one secure place where you can access, or through that you actually can access all the pertinent records for all stakeholders. That includes the patient. The patient can be part of the decision. The patient can be part of the care. And the patient is empowered to actually take charge of their own care.
Yeah, I appreciate you. is what I can say to that. And I'll say my 2 cents from a caregiver perspective and a patient perspective. The word that's really resonated with me is teamwork. And wishing and that having it in that one place is about teamwork. We have a team. We no longer have one person. Somebody said, I wish we could go back 20 years when you just had one doctor and that doctor had to take all the information. Well, now there's 10 doctors and you have a team of people. And imagine setting a football team out on the field with no playbook, ready, hike. Could you imagine everybody's just, oh, I didn't know you were tossing me the ball. I don't like, you got one guy's running down the field. The other guys were getting ready to kick. That's exactly. And then they're all trying to communicate at the moment. And it's this, and there's all these burdens in between. And you could say, well, I don't know, my hearing was bad that day, or my helmet was twisted, right? That's, to me, it was like, really, I don't know when I started, maybe about a month ago, that I was like, think about it like if you went into a team sport and you weren't all working off the same playbook. And that's what the records and consolidation of that, what does that patient want? Shared decision-making. We talked about that, Levi, right? What does the patient want to do? I think, my other thing that I got into as we went forward was the patient has to own their health as well, because outcomes are dependent on their ability to manage their own health, but they need to understand what that information is, and they need it in non-medical speak because none of us can read that medical. So I think we'd truly look at it like a team, and the person who's at the center of that, people call it patient-centered care, but it is really about teamwork, and that the team can only work as good as that playbook looks, and all of that information has to be there. And you have to have, it's like a relay race. I got all these analogies where, like, when are you picking up? What information do you need? If I give you too much information when I'm handing the baton off, you have to sort through it all and figure out what it is that, like, Ulrike and I are running together, and I got to listen to all the gobbledygook before I get to, like, hey, Shannon, run to the left. But it's surrounded by all this data. And that's, to me, teamwork just keeps going. And teamwork is about helping that person next to you transition that information, not just shoving stuff off. And that's what happens with faxing of records and faxing of data. Doesn't allow, it just more noise, which you would never do in a team environment. You just wouldn't. You'd be thinking about what that next person has to do. So I'm getting really excited, Levi. You like it when I do this. So I say, Ulrike, on top of that, like 1, 2, and 3, it's about teamwork. It's about the group. It's about making sure that the right people have the right data at the right time to make a quick decision, and that patient is an active part of their care.
Who kind of a closing question then for both of you. Who would be the quarterback? I know we're talking American football here, or you cannot football.
Oh, right. International.
Who would be the quarterback, in this situation? Is it still the patient? Is that when we talk about playbook, we're using the sports analogy. It's the patient, right?
You want to take a stab, Ulrike, or you want me to go?
You need to go because my knowledge about football is pretty low, but soccer I can play soccer.
Well, or rugby. Rugby is very similar, but rugby does have like it's a little bit different. There's no quarterback, I don't think. And in soccer and rugby, there's no quarterback. I think, and that might even be insightful, and that's probably the better way to say it is in soccer and rugby, you don't have a quarterback. In American football, you do. They're just the one that calls the play, snaps the ball. I feel like it's the patient and the provider. It's not one person. It's the patient provider. The caregiver is often in that, right? If that patient isn't prepared to make those decisions. So maybe there isn't one quarterback, because actually now you say that, I'm like, what if we got too many quarterbacks on the same team?
Yeah.
I think you said that about it's the teamwork. You know, you gotta. It's kind of conversion to the same goal. Everyone contributes in the same direction.
Well, I think football, I say football as a soccer. With soccer, it's probably a better even analogy.
Better,
As
yeah.
there's this seamless on-field play where everybody to just score a goal, right? In soccer,
Mhm.
you have to be in unison as a team. It's almost impossible to be an effective soccer team, if everybody's kind of going to do their own thing. Whereas in football or even basketball, you can have an amazing superstar and you can get away with maybe other
That's- You know what? You know what? Rugby might even be better, because rugby is literally rugby is like the pace goes, and you are making snap decisions at the time, and there's no stop of play. You just go, and it's called a gentleman's sport if it's not played well. If it's played well, it's a gentleman's sport because it's the most beautiful. It's the most beautiful game to play, even though it looks harsh. And you have to be in unison. But the minute people start not playing together, it is ugly. People are getting hurt. So yeah, soccer or rugby. I think we'll have to look into that now.
That'll be
I'll just switch my
podcast
analogy.
around two of the Ulrike. So, we've taken so much of your time today, and I really
Yeah.
appreciate it. And I'll close it out and let you guys all say thank you. But thank you so much for coming on our show today.
Ulrike. Yeah, no, Ulrike, thank you for joining us. This is awesome. Like Levi said, we may ask you to do a part 2, because the first one is always interesting, where we're trying to figure out what we really want to focus on. So thank you for spending the time with us and sharing your knowledge. And then make sure when you close up, you just kind of let us know if we can have people reach out to you. Do you want to let people know they can reach out to you? Let us know. We can do that too.
Well, thank you. It was a definite pleasure to be on your show, and thank you so much for what you're doing with Ursamin. And yes, if people want to reach out for me, it's my full name. I have a website or LinkedIn, just Ulrike Berzau.
Yeah,
Definitely.
In the show description. So, thank you so much. And, Unlimited Access is a show for Ursamin. And Ursamin, we believe people, patients, the caregiver, everybody provided on that team with shared information. They can make shared decision making. And we believe that's the best situation for everybody in the healthcare system. So thank you so much, and bye.
Thank you. Bye-bye.
Bye-bye.